Good afternoon. I am Dr. Surender, Professor of Anesthesia. Today I will be discussing about regulation and interpretation of arterial blood gases. Arterial blood gases interpretation is very important because acid-base regulation plays an important role in maintaining the pH, which is necessary for maintaining the homeostasis of the body. The enzymes may not function properly if the acid-base derangement will occur, and it can have lethal complications. Before we go into the details, let us discuss about the basics of acid-base balance. Acid is any substance which forms hydrogen ion in solution when it is dissolved in solution. In other words, it is a proton donor. Base is any compound combines with the hydrogen ion, and that is proton acceptor. The strong acid one that ionizes completely in solution releases lots of hydrogen ions, thereby changes the pH drastically. Whereas a weak acid is one, only fewer hydrogen ions are released as a result of that one, because it ionizes partially. The primary system that regulates hydrogen ion balance is immediate chemical buffering mechanism, respiratory compensation, renal compensation. When the acid-base derangement occurs, buffers will come into action. They limit the change in the hydrogen ion concentration when hydrogen ions are added or removed. These buffers are weak acids and bases. It is like a sponge. Whatever excess hydrogen ions is there, that will absorb. When there is a short supply, it will squeeze out and release more hydrogen ions. But you should remember that buffer cells get a limited capacity. It will work in few minutes time. There are important buffers in the bicarbonate buffer, hemoglobin, intracellular proteins, and urinary buffer ammonia. Bicarbonate buffer is a combination of weak acid, carbonic acid, and bicarbonate salt. When a strong acid such as HCl is added, it combines with the bicarbonate and forms a carbonic acid, weak acid. A strong acid capable of releasing lot of hydrogen ions and changing the pH drastically is converted into a weak acid, fewer hydrogen ions are released. As a result of that one, pH change is minimal. When a strong base such as sodium hydroxide is added, sodium hydroxide combines with the carbonic acid to form sodium bicarbonate, which is a weak acid base. Thereby change in the pH is minimized. Respiratory regulation, whenever there is a hypercarbia, pH decreases, alveolar ventilation increases. That washes off carbon dioxide. As a result of that one, pH is restored to normal. Vice versa will occur in respiratory alkalosis. Renal regulation, a fundamental mechanism by which is reabsorption of filtered bicarbonate, secretion of hydrogen ions, production of new bicarbonate. These are the three mechanisms by which kidney regulates the acid-base balance. All the bicarbonate which is there in the body will be filtered. If the bicarbonate is not absorbed, patient will go into severe acidosis. Since this tubular epithelium is a biological membrane, there are positive and negative charges. They will not allow the charged particles to come. As a result of that one, a charged particle cannot enter unless there is a depolarization. Yes. Or if there is a active sodium-potassium pump is there. So bicarbonate divides into tubular lumen, divides into sodium and bicarbonate. Sodium is reabsorbed by this active sodium-potassium pump. In place of one positive ion enters the cell, another positive ion has to go out. As a result of that, an hydrogen ion is thrown out. So it combines with the bicarbonate to form carbonic acid, which will dissociate into carbon dioxide and water in the presence of carbonic anhydrous. Then carbon dioxide freely diffuses into the intracellularly, combines with water to form again carbonic anhydrous, bicarbonate, carbonic acid. Then it is dissociates into bicarbonate and hydrogen ion. This bicarbonate is absorbed into the bloodstream. This hydrogen ion again enters into the lumen and taps another bicarbonate. There are other mechanisms by which phosphate mechanism and ammonia mechanism, due to lack of time I am not going into the interpretation of arterial blood gas. Collection of sample is very important. Heparinized cylinder you must use. There should not be any air bubble in this one. And wherever end arteries are not there, such arteries only you can handle. Radial artery and femoral artery are the commonly used arteries, but you can take from any artery. Allen's test is must before doing the radial artery puncture. Then one can enter into the radial artery at 45 degrees. And when free flow of blood comes, then withdraw the blood, take out the air bubbles, and bend the needle, keep it in the, immediately analyze or store in a cold ice and transport and do the analysis as early as possible. Interpretation of arterial gases before you do, it will give what is the abnormality. It will not give a diagnosis. For diagnosis purposes, you have to go into detailed history, clinical examination, investigations such as complete blood picture, serum electrolytes, sugars, renal function tests, etc. Oxygenation and ventilation status, how much of FiO2 patient is getting is very important. It should be known so that you can interpret. Measures of oxygenation. Oxygen saturation has got a limited value because it is will not reflect unless the oxygen tension falls steeply, then only the oxygen changes in the oxygen saturation or dissociation curve will occur. Arterial oxygen tension. This is a better index than the saturation. But this has also got a limitation. This is known only by analyzing the blood gas sample. Calculating the arterial and alveolar and arterial gradient gives better indication. PF ratio is still better. AA ratio, PF ratio is same important. Oxygenation index is used for only certain pediatricians. The alveolar oxygen can be concentrated by this alveolar equation. So by this you can know what is the alveolar oxygen tension minus arterial gives the difference. Normally difference is less than 25, patient is breathing on room air, more than 150, less than 150 is breathing on 100% oxygen. If you see both the patients are breathing 21% oxygen, two different patients, but their PaO2 levels are 45. But if you analyze, so PaO2 is not a very significant, will not give a proper indication. When you analyze the alveolar arterial difference, this is normal, whereas in this case it is 55. Erased. A wide gap indicates that it is oxygenation failure, whereas a normal gap indicates that it is a ventilatory failure. PF ratio is more sensitive than all these things, and usually it is 3. The PaO2 by FiO2 ratio is 300 to 500. Less than 300 indicates abnormal gas exchange, less than 200 indicates severe hypoxemia, and we can diagnose the ARDS. AA ratio, alveolar to arterial, arterial to alveolar oxygen ratio. This is also one of the indicators of oxygenation status. Oxygen index usually we don't do. This is useful for ECMO purposes. These are the normal values of pH, PCO2, 40 plus or minus 5, 7.40 plus or minus 0.04, 24 plus or minus 2 bicarbonate, base excess is 0 plus or minus 2. The base excess is the amount of acid required to restore the 1 liter of blood into normal pH. This indicates only pure metabolic component. This is the derived. Standard bicarbonate is when blood is equilibrated with the carbon dioxide of 40 millimeters of mercury. Whatever the bicarbonate we get is the standard bicarbonate. It indicates purely metabolic component. 6 steps for successful blood gas analysis. First step is whether you should know whether there is a acidosis or alkalosis. Look at the pH. If the pH is less than 7.35, it is acidosis. pH is more than 7.45, alkalosis. This is a normal pH. 7.52, alkalosis. Second step is determine whether it is a metabolic or respiratory. Low bicarbonate acidosis is caused by loss of acid, base, or gain of acid. So if there is a loss of base, gain of acid is there, it is acidosis, respiratory and metabolic, respiratory. If there is a gain of base, loss of acid is there, it is alkalosis. Second method is trend in which it is going. So that will give an idea. This indicates that there is an acidosis. Raise in bicarbonate, can it explain acidosis? It will not explain. Gain of acid, can it explain acidosis? Yes. So this is a respiratory acidosis. Here 2 children are playing. Left side they are playing on the seesaw board. When boy is going up, girl is coming down, and vice versa. Here both are playing in the swing. They are moving together, whichever direction it is going. So if pH, think that boy is a pH, girl is a carbon dioxide. If they are moving in the opposite direction, it is a respiratory problem. If they are moving in the same direction, it is a metabolic problem. In pure disorders, metabolic acidosis, when pH decreases, carbon dioxide is also decreasing. So it is a metabolic disorder. In both the metabolic in respiratory disorders, they are moving in the opposite direction. 7.30. It is a acidosis. They are moving in the opposite direction, same direction, metabolic acidosis. 7.32, acidosis. 60, carbon dioxide is raised. Respiratory acid increase, respiratory acidosis. They are moving in the opposite direction. This is respiratory acidosis. When you are faced like this, you have to explain which direction, how much change in the acid, how much change in the base. You have to calculate. Change in the acid is 8 by 40, that is 20%. Change in the base is 12.5. Whichever is the greater, that is a primary abnormality. So primary abnormality is respiratory acidosis. So this arrows will work only certainly. This is the definitive method. Then the third is respiratory acidosis there, whether it is acute or chronic, you have to determine. The pH changes by delta pH is 0.08 into change in the PCO2 by 10. That is for 10 millimeters, 0.08 change in the pH will occur. So, if the 10 millimeters of carbon dioxide pH changes to 0.08, it is an acute disorder. If pH changes to 0.3, it is a chronic disorder. If the pH changes in between, it is partially compensated. Take for example 7.24 pH. PCO2 is 60. 60 means 20 millimeters rise. So 1.16 change. So if you take out that, it will come 7.24. It is acute respiratory acidosis. So thereby we can differentiate between the acute and chronic. That is simple or mixed disorder. Without going into the details, it is the bicarbonate to acid ratio that will determine the pH. Whenever bicarbonate increases, acid also increases. The ratio is the pH. Whenever bicarbonate decreases, acid also decreases. So in metabolic acidosis, bicarbonate is decreased, base loss of base is there. So acid also decreases. When there is a gain of base is there, acid also increases. And vice versa in respiratory diseases. In simple disorders, they move in the same direction in the metabolic, opposite direction in the respiratory. If they are moving in the same direction, carbon dioxide and bicarbonate, then it is called simple acid-base disorder. That is purely one disorder is there in the body. In mixed disorders, they move in the opposite direction. Acid-base direction in the same side, simple disorder. Let us take one example. This is acidosis. Bicarbonate is 30. Metabolic. Simple. Acidosis. Bicarbonate is, carbon dioxide is 60. Respiratory. This is a mixed disorder. To be specific, it is a respiratory acidosis with metabolic acidosis. In a respiratory acidosis, when acid increases, you expect base to increase. On the contrary, base is decreasing. Means there is an additional component of metabolic acidosis is there. But these arrows and will give to some extent. If it is a mixed disorder, complicated disorder, it will be difficult and it will not tell how much is the difference. So corrections we have to make in acid-base balance, we have to know definitely how much of carbon dioxide deficit is there, bicarbonate deficit is there for correction purposes. So hence we have to calculate the method. Then we use usually Winter's formula to calculate the metabolic acidosis. That is 1.5 times the carbon dioxide plus 8 plus or minus 2. This is the formula we use for metabolic acidosis. Metabolic alkalosis 0.7 times the bicarbonate is plus 21 plus or minus 1.5. Then for each 10 millimeters of change in the carbon dioxide, increase or decrease, in acute condition, it changes by 1 milliequivalent. For 10 millimeters, 1 milliequivalent. And chronic 4. And acute respiratory alkalosis 2 and 5. So we call it as a 1425 formula. (7.21) acidosis. Respiratory. We have to calculate how much change in the deficit. Estimated is 16. Calculated or expected is 26. There is a deficit of 10 bicarbonate is there. There is a loss of base of 10 additional, not explained by the respiratory disorder. So that is the additional component of respiratory metabolic acidosis coexisting with the respiratory acidosis. Here the formula is bicarbonate is decreased, pH is decreased. So acidosis, it is a metabolic origin. Bicarbonate is, the carbon dioxide is 17.9. So we have to calculate how much is the, using the formula. We have calculated and it has come as 17.9. So actual is, it is coincide with the estimation. So it is a compensated metabolic acidosis. Anion gap. Whenever there is a metabolic acidosis, you have to calculate the anion gap. Anion gap is sodium minus bicarbonate plus chloride. So usually 12 plus or minus 2. This is because of the unmeasured ions and unmeasured cations, which usually we don't estimate all these things. If there is a high anion gap is there, think about methyls, ethanol, uremia, diabetic ketoacidosis, aldehyde infection, lactic acidosis, ethylene glycol, salicylate. If there is a normal anion gap is there, think about Grahams, diarrhea, erythrocyte, fistula, urinary, renal tubular acidosis, hyperalimentation, acetazolamide, miscellaneous conditions. Anion gap is only clue to identify hidden metabolic acidosis, like fingerprints which will catch the criminal. So analyzing this will help us to know about the cause, what is the cause for metabolic acidosis. Here pH is 7.30, acidosis. Low bicarbonate suggests that it is a metabolic acidosis. In metabolic acidosis, we use the formula, Winter's formula, calculated as come as 13.5. This is also 13.5. So it is measured. There are other methods by which we can calculate the bicarbonate. How much carbon dioxide we are calculating Winter's formula. Instead of that one, we can calculate first two digits of pH corresponds to the carbon dioxide. This is another formula. This would work for simple metabolic acidosis. If it is a mixed one, it will not work. Similarly, there is another rule is bicarbonate plus 15. So that is also works only if there is a mixed, simple disorder. If there is a mixed disorder, you have to go by Winter's formula. Remember that. So it is a simple metabolic acidosis. Expected carbon dioxide, expected bicarbonate. Then anion gap, when we calculated, it is come as a 10. So it is a normal anion gap, metabolic acidosis. We have to think about dirhams. Compare bicarbonate with delta bicarbonate with delta anion gap. If delta anion gap is equal to delta bicarbonate, it is a high anion gap metabolic acidosis. If delta anion gap is more than the delta bicarbonate, it is an additional metabolic alkalosis is there. If delta anion gap is less than the delta bicarbonate, non-anion gap metabolic acidosis. 7.14 acidosis. Bicarbonate is low, suggests metabolic acidosis. Then when we calculated the expected carbon dioxide, 45 is the estimated. There is a loss of carbon dioxide less than the expected. Not matching, suggests to additional respiratory acidosis. So it is a metabolic acidosis with respiratory acidosis. Anion gap is high. So it is a high anion gap, metabolic acidosis with respiratory acidosis. Now we have to estimate delta. Anion gap is 13. Delta bicarbonate is 7. Delta anion gap is more than the delta bicarbonate. So it is additional metabolic alkalosis. So if patient has got high anion gap metabolic acidosis, metabolic alkalosis, respiratory acidosis. There are 4 acid-base disturbances are there: respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. Out of 4, only 3 can exist at the same time: respiratory acidosis and respiratory alkalosis cannot exist together. Interpreting ABG is not a magic. It takes little practice.